Hello and welcome back to TiCME. Today's talk's just going to be a potpourri of broad complex rhythms, and this is a talk that I recently gave at the Sri Lankan Society of Critical Care and Emergency Medicine's annual meeting in Colombo. It's good to have everyone back again. So as everyone knows, broad complex rhythms are pretty common in ED, and you need to make sure you get the diagnosis right so you can treat people. So firstly, when you get someone who's coming with a broad complex rhythm, the question is, are they stable or unstable? Is the rhythm wide or narrow? And then, is it regular or irregular? Secondly, if it's fast and the patient is unstable, don't think too hard about it. They're going to need a shock. Alright, and thirdly, if you've shocked a patient or they're not unstable and you have a chance to think through it, you need to think about whether the broad complexes are supraventricular rhythms which have got some sort of aberrant conduction in the ventricles, or whether they're supraventricular rhythms that are getting to the ventricles via accessory pathway, or whether they're ventricular origin rhythms. So case 1, a 50-year-old man comes in with severe chest pain in the resus bay, no significant past medical history, he's not a smoker, but he said that his father died at the age of 47 from a heart attack. There are ECG leads on and recording, at which point he promptly arrests. And this is the ECG that prints out. Everyone probably is reasonably happy that this is a broad complex regular tachycardia. So pads are applied and is defibrillated with 200 joules, unsynchronized biphasic shock, and has rapid return of spontaneous circulation. Another ECG is done. And this is the ECG that was performed. So if we look carefully, you can see there's obviously a ventricular ectopic beat at beat number 5. But there is a whole lot of ST depression that goes from V2 through to V6. And then there's this elevation of the ST segment in ABR, which is greater than the elevation next door in V1. So the patient was treated for a STEMI and had 100% left main coronary artery occlusion at angiography. Okay, so the ABR ST elevation pattern has been well known for quite a few years, but if you're not aware of it, you need to see ST elevation in ABR, which is greater than ST elevation in V1, and you should also see anterior and sometimes lateral ST depression as well. So back to the wide complex rhythm the patient had. His first ECG is absolutely typical of a monomorphic VT, and classic features here include all the complexes look the same, so monomorphic, it's regular, it's broad, and it's at a rate which is not unreasonable for VT. What about the rate? Well, when you've got a broad complex rhythm, you can break it down into a ventricular escape, which is defined as a rate less than 40, an accelerated idioventricular rhythm, or idioventricular rhythm, which is 40 to 110, and then VT is more than 110 and usually less than 200. And VT is actually a reciprocating tachycardia involving the ventricle. But not only does this man have morphological criteria that support VT, he is a 50-year-old male having chest pain. And in 2 studies, these clinical factors alone make you more than 98% likely to have VT as your diagnosis at EP studies when you present with a broad complex tachycardia. Morphology is unreliable sometimes, particularly at the higher rates. But even if you're not sure, you still have an 80% chance of being right if you call every regular broad complex tachycardia VT. But there's always more, isn't there? So case 2, a 4-week-old baby girl presents with poor feeding fatigue for 3 days. She looks a little blue when feeding. Her pulse is too fast to count, she's afebrile, and she's got crackles in both her lung bases. This is her ECG. It's not a great projection, but it is the actual ECG from this girl, so it is important to see it. What you've got is a very fast, regular, broad complex rhythm with a left bundle branch block morphology with these great big deep S waves in V1 to V3. She was going at 276 beats per minute when she turned up. There was no clinical features of congenital heart disease or other dysmorphia. And she'd been in this rhythm probably for 2 to 3 days on the history. Remember, she's not a 50-year-old male with chest pain, so VT is less likely, but certainly not impossible. In terms of treatment, given that SVT was more likely, she was given adenosine in progressively higher doses, and that failed, so then she was gently sedated with a little bit of midazolam fentanyl and then given a 2 joule per kilogram synchronized cardioversion, which was successful. She was retrieved back to the high-level cardiac NICU, but was back to a healthy, happy self by the time she got there 4 hours later. Her echo was done, was entirely normal. So what did she have? In fact, she had an AV nodal reentrant tachycardia, so paroxysmal SVT with left bundle fatigue. So what happened was that over time, the left bundle just stopped being able to conduct properly because of how rapidly and how often this little heart had to depolarize. So what was a narrow complex rhythm had converted to a broad complex rhythm, and in fact she presented in left ventricular failure. So what is AV-NRT? Well, there's fast and slow limbs for conduction in the AV node, and usual conduction is antegrade, so from atria to ventricle down the fast limb. Typical AV-NRT is usually initiated by an extra atrial beat that blocks in the fast pathway and then conducts over the slow pathway. Now, if by the time that beat gets to the bottom of the slow pathway, the fast pathway is ready to conduct again, the impulse will conduct back up the fast pathway, resulting in an atrial echo, which will generate an inverted P wave. If the impulse will re-enter back into the slow pathway, you then get the circus rhythm of AV-NRT. The P waves that were formed from this little atrial echo are buried in the QRS because the atria and the ventricle are now depolarized at the same time, and they manifest as what's called pseudo S waves in 2, 3 in AVF and pseudo R waves in V1. You can treat them usually with vagal maneuvers or adenosine and sometimes verapamil, and if that doesn't work, then cardioversion is the right treatment. So remember to think about VT versus SVT with aberrant conduction by thinking about degeneration of the impulse, whether it started above the ventricles and then been modified somehow by a bundle branch block or by using accessory pathway, or whether the impulse has been generated in the ventricles itself. So case 3, a 75-year-old lady with comorbidities including ischemic heart disease, chronic renal failure, type 2 diabetes, is brought in by ambulance feeling generally unwell and weak. She's usually independent of activities of daily living, and physical exam reveals a frail old lady with an elevated JVP, borderline hypotension, pulse of 90, SATs of 92%. That's her, quite frail as you can see. You get an ECG, of course, and here it is. So this is a broad complex rhythm. It's not particularly fast, and you wonder what sort of rhythm it is. So you first of all look for P waves, and looking down in one beat you can't see any, so it's probably not a rhythm that's generating P waves. And you look at these great big peak T waves in the broad complexes and you wonder what this could be. So you immediately arrange a blood gas, and the results are cooking on the machine when the patient suddenly becomes very drowsy and pale, and the rhythm strip prints out from your central monitor and is given to you. And this is what it looks like. So what we've got here is still not a particularly fast rhythm, about 100 beats per minute at the most. Broad complex, really lost a lot of definition of the QRS complexes and T waves now. In fact, it's looking more like a sine wave. So what's the cause? So here's the blood gas. I won't make you pore over all the details. Suffice it to say, that's a potassium of 8.57. So you immediately treat the patient with calcium gluconate, insulin dextrose and salbutamol. The ECG normalizes and she's referred on to the renal team. So this is hyperkalemia. How does hyperkalemia work to make a broad complex rhythm? Firstly, what it does is make the resting membrane potential more positive. Now, the most important thing that does is reduces the difference between the resting and the threshold. So normally there's a difference of about 15 millivolts, so it takes a fair bit to kick off the depolarization. But in hyperkalemia, it's often 5 or less. Also with the hyperkalemia, the repolarization period is shortened. What happens is, surprisingly, the atria is actually quite resistant to the effects of hyperkalemia. Now, because of all this suppression of the action potential, you don't actually see P waves, but the atria is usually still firing, and that's called a sinoventricular rhythm. You're just not getting P waves seen. So that's why this rhythm isn't super fast. The QRS complex spreads right out, and so it's common that it's thought that this rhythm from hyperkalemia is VT. Now, it's not VT. Remember, VT is a reciprocating tachycardia from the ventricle. This is a sinoventricular rhythm, and shocking the patient is not going to be successful. So you need to aggressively treat the potassium. All right, we'll move on to case 4. A 19-year-old man comes in with palpitations and dizziness, and this is his ECG. Now, this is a bit more chaotic looking than the ones we've seen so far. What we've got is an irregular rhythm that's broad complex. But importantly, within the broad complex, there's a significant morphology variation. It's almost like every beat is different. So this is Wolff-Parkinson-White and pre-excited atrial fibrillation. Wolff-Parkinson-White, as you know, is a rhythmogenic disorder where there is an accessory pathway which can conduct the depolarization wave from the atria direct to the ventricle, missing out on the AV node and the bundles. You can have orthodromic reentry tachycardias, which are narrow complex, so they're tachycardias that go down the AV node and back up the accessory pathway. Antidromic reentry tachycardias, which are broad, or atrial rhythms conducted rapidly via the accessory pathway, like in this case with pre-excited AF. When we draw a picture of what's happening in sinus rhythm, we get a delta wave because the P wave goes down the accessory pathway faster than it goes down the AV node and causes early depolarization of the ventricle, or pre-excitation, so it's a short PR and delta wave. In an orthodromic AVRT, so atrioventricular reciprocating tachycardia, we go down the AV node and then back up the accessory pathway. And an antidromic, the Warring type, we go down the accessory pathway at high rate and then re-enter via the AV node. So pre-excited AF, the hallmarks are it's irregular. There's a non-isoelectric baseline because we've got a fibrillatory wave running from the atria across that, and there's morphology variation within a lead. And that's due to the variable pathways that the beat can conduct. So it can go through the AV node or the bypass tract or through both at once. Remember that if you're going to shock someone in Wolff-Parkinson-White, you need to watch out that you're getting good synchronization. If you see my WPW talk, this is this case again. So this person was shocked for their pre-excited AF, this 19-year-old, and went straight into VF, and then was unsynchronized shock with 200 joules and reverted to sinus, thankfully. And he ended up having a defibrillator R on T, which was predisposed to by his rapid rate, making it harder to identify the R waves, long relative refractory periods in Wolff-Parkinson-White, the unusual QRS complexes interfering with recognition by the machine, and in this case there was S waves in the lead of the defibrillator, not R waves. The other thing was he only had 100 joules for his initial power setting, which is probably not quite enough. You probably should, if you're going to defibrillate with Parkinson-White, avoid using an S-wave lead to monitor. Shock when they get a bit slower because their rate does vary up and down a bit. Use a higher power, so 150 or 200 joules to start with, and print a strip first to ensure that you're synchronizing properly before you hit go. Okay, case 5. A 45-year-old male comes in after an arrest at work. The AMBOs do a fantastic job of fixing this rhythm, which is VF. He arrives awake and tells us that his brother and his dad died of a heart attack in Iran. An ECG gets done. And it looks like this. So he's in sinus rhythm. But it does look a bit funny here in the septal leads. There's this ST elevation pattern from sort of V2 and V3. Not classically horizontal, but still a bit worrying. So he's given aspirin and oxygen GTN, his pain resolves, chest x-ray was done as entirely normal, and an ECG was repeated. So at 30 minutes ECG now looks like this. So there's been substantial morphology variation. We've now got ST elevations greater in V3 and an RSR prime complex and broad complex in AVR, and still this funny looking V1. So we thought the diagnosis was now probable. The cardiologist agreed to do a test. What test did they do? Was it an angiogram? Was it something else? So this is ECG during the test. And you can see now in these septal leads that we've been looking at over and over, that now we've got these very unusual biphasic T waves and funny looking ST elevation, which is described as coved. Do you know what this is now? So this is Brugada syndrome. Brugada syndrome affects about 0.3% of the population in the West and a bit more in Asia, where it's more prevalent in Southeast Asia, particularly Cambodia and Laos. It affects males much more than females. Now it's a disorder of sodium channels, like long QT syndrome is. There's three main subtypes, although there's so much variation that these are probably not particularly useful in practice. There's type 1, type 2 and type 3. Right, so we'll move on. We're just going to whiz through a couple of very quick cases now. So polymorphic VT is often confusingly named torsades when it might not be classic torsades, and otherwise people just call it polymorphic VT. So what's the difference? In torsade de pointe, the polymorphic VT has been preceded by a long QT interval. In polymorphic VT, there's no long QTC preceding. You don't get classic twisting of the points unless there's a long QT. So this is polymorphic VT, and you can see that there's a normal QRS before it, no long QT, but there is ST elevation in lead 2. So this person's having polymorphic VT, which has been turned on by an infarct. And here is someone who's got a long QT, which is now led to a torsade de pointe. What about this one? This isn't particularly fast. It looks a bit like that hyperkalemia ECG we saw earlier, didn't it? This was sometimes being mislabeled as a wide complex tachycardia, but in fact, this is a lead 2 printing out from a rhythm strip, and it's an inferior STEMI with massive ST elevation. Here's one we saw the other day. This is a broad complex tachycardia at about 125 beats per minute. This is actually a pacemaker mediated tachycardia where the atria and ventricular leads of the pacemaker can actually form a reentrant circuit. In this situation, you usually sit at the rate that your pacemaker's max setup, and they're often between 120 and 130, which is one of the giveaways. Here's another funny looking VT, where what we've got here is a native VT with someone with an AICD in, and then what it's done is run through a burst pacing, overdrive pacing cycle where it's given 8 faster shocks, so it's overdrive pace the patient out of their VT and into this sort of ugly looking wide AF. What about this one? Some of these ECGs get called VT, and the commonest reason is because shiver artifact is up on a monitor, not on a 12 lead. So if you have a look at leads 1 and AVL, you get a significant shiver artifact. Sometimes you can have auto gain settings on the ECG which actually turn up all of the signals and make it look exactly like VT. So if you're looking at a rhythm strip and you see what you think is VT, be sure you confirm it by holding the patient's pulse. So in summary, ED sees lots of broad complex rhythms. We see more than just the diagnosis of VT or aberrant SVT. Morphology does make a big difference, but clinical context is everything, and treatment depends on getting the diagnosis right. Remember, if the patient is unstable with a broad complex rhythm, the treatment is shocking. Thank you very much.